And now closing remarks will give Dr. Nagi or Nagi. Thank you.
Now our last presentation will be by Dr. Hussin Nagi from UK, originally from Egypt. Yes, please.
Assalamu alaikum. I'm glad you're still here. My job is a bit difficult because I'm trying to summarize what have been said for the whole day. You have seen me writing all day, so I'll try with apologies to anybody who I might skip their name, title, some of the important things that they might think was important in the lecture, but you have record of all the lectures, and I'm just going to give you an overview for what have been said today. We started by Professor Rida Howard, who started with us 3,000 years BC, and the most important message for me from his lecture, apart from the nostalgia about being Egyptian and it started in Egypt, that at that time there was supervision and there was some inspection on people practicing hijama. That is very important. Then Professor Yusuf talked about evidence base, and he went through the hierarchy of, you remember that pyramid, and unfortunately till now we don't have that magic word, double-blind randomized trials. We are asking all of you to think, how can we do double-blind cupping? Acupuncture was blocked in the West for centuries because they could not double-blind patients. You either have a needle or you don't have a needle. Till somebody invented telescopic acupuncture needle. And that opened the gate for double-blind studies. And this is why acupuncture now, you cannot argue, because everybody know double-blind randomized study. The golden standard of evidence-based showed that it works. So we are looking for that, I would say, magic cup that can do cupping without cupping. Professor Merrim then went to the history of Europe, and I'm not going to go through that. It's a fascinating journey. But what I take from his lecture is really why we are here. It looks through his historical overview that hijama was practiced by respectable scientists, and it was thriving. Then modern medicine came in, it came out of favor, so it started to be practiced by non-professionals. Then it started to be attacked. So our gathering in this conference and similar conferences is to bring it back to high standard. This is why we are here. So this is what I take message from Professor Merrim. Then Professor Sulaiman was talking a beautiful talk about techniques. And I would really want to watch this specific lecture again and again, to review my technique and to be able to explain to patients, why do I do the cup first? Then why I remove it? And then why do I do scratches? And then why do I put the cup and then suck again? The 3S. Suction, scarification, suction. And then you heard our Chinese colleagues who are doing 1S or only 2S, and how superior the 3S, it makes sense. Obviously, if other factors like pain, I can't believe what I heard as anesthetist, our colleague, Professor Ali, who put a patient to sleep to have hijama. That is beyond my imagination. I have never
Yes.
even heard of this, but it's fantastic. If I have if I have the facility for many of my needle phobic patients, who all what I do in my life is injecting people. Okay, so you can imagine, most of my clients are needle phobic. So why do you come to me? It put me in a great challenge. I cannot put a patient to sleep to have an injection. It doesn't make sense, but if you can have it, by all means. Then we talked about our brother, Dr. Muhammad Bushnaq, talked about the holistic approach, which is something that really, I can tell you, there are good doctors and bad doctors. They all graduate. They all get marks. They all pass the exams. But there are some who are, you can tell from Muhammad when we were standing here, how passionate he is about that patient. He takes that holistic approach. He asks about family. He asks about the will. What is after? What do you want? How do you want it to end? And so on. So this is very important to take that holistic approach. The only thing prevent us as doctors from this is time.
Yes.
Believe me, we have been working in all countries like robots. You need to produce how many patients in some certain number of so many numbers in specific time. So you don't have that luxury of sitting, talking, starting to build rapport, joking, admonishing the dress or the accent or how's your son or and so on, because of the time. So this is something we really need. Maybe when we do hijama, we need to facilitate that time. Don't overbook yourself, so you're not just stabbing patients and cupping and sucking. You need to have that time. Then it was me who talked to you, and I'm not going to not to talk to you again. Who should do it? Where should do it? And we looked together with pros and cons of doctors versus non-doctors, and that is, I think, is still kind of materializing in people's brain. We have seen many countries start with doctors only, and then start to ease off to try to train non-doctors. And then even in Bahrain, they had to come under the pressure of the public. They acknowledged the traditionalists who are not medical trained, and they got them, they stamped them, they told them what to do, what not to do, and it becomes a fact. The people listened, or the government listened to their people, and it is reality. If you don't do it, it will be done under the carpet. So you might as well just address it and have some control over it. Then we heard our Chinese Professor Wu Chen, his representative. There were so many things beyond my understanding, or when it came to Chinese medicine, believe me. The heaven, man, and earth hierarchy theory, I need to know more about it. The sliding technique, how you do I do sliding technique as a deep massage, but not a diagnostic tool. They seemingly use it as a diagnostic tool. So something for us to learn. It will be really a challenge for historians. Who started hijama first, Egyptians or Chinese? I think that might be another conference that need to be done in the United Nations. Maybe.
China and Egyptian.
Wallahi, I believe this is knowledge that Allah taught to Adam alayhi salam.
But I know who.
This is my belief. Yani my belief is وَعَلَّمَ آدَمَ الْأَسْمَاءَ كُلَّهَا. Allah taught Adam all the knowledge. Some of it was hijama. So some nations took it and practiced it and invested in it. And that's why in Africa, how come Africa to Anatolia, to Finland, to Mexicans? Where is the connection? Adam. That's my small theory anyway. Then Professor Ahmed Al-Alami and Professor Abdul Jawad, we didn't have a chance to listen to him, but their experience about how this was done systematically in Saudi. I was there when they banned hijama. I was in a conference and I heard it with my ears. The Minister of Health said to that conference, if the word hijama will be mentioned, the conference will be cancelled. And we were shocked in Saudi. This is now you heard, because the spread of hepatitis C by non-professional practitioners. So he came really hard, but it took them up to 2015.
Can I add something?
So it took them 8 years to bring it back to life again. Okay, excellent work. But during these 8 years, what happened? I don't know who got hepatitis, who could have been prevented from having it, who did not benefit from hijama. It's something for other countries. When you are going to block, you need to block very quickly and have the alternative very quickly. You cannot just block and wait for 8 years with nothing alternative.
Dr. Nagi, can I add something? Because I was all those years in Saudi Arabia visiting monthly on work. It was so common and usual to do hijama on streets. And it was out of mind to see. Alhamdulillah, I haven't seen it like as a neurosurgeon. And they decided to ban it completely, to stop that practice. And they said it is banned unless medical science give a confirmation of its actions. So they spent a few years in vacuum. In that, in the meantime, they made a place of in Ministry of Health, vice minister, something like that, for traditional medicine. And then they they made plan, start to certification of doctors who were performing before hijama. Then they gave them license, and after medical centers they were licensing. Maybe I speaking like idea for this region for some.
I think it's an excellent model to have a heavy hand. From all my concern is the length, but that heavy hand was good to stop and put an infrastructure. So we have now courses, as far as I understood, it's 60 hours or 20 hours, 80 hours or 40 hours, depending, are you medically trained or non-medically trained, and then certified. And then you have the safety, the professionalism, the research, the evidence-based, and they showed some publications, 25% of the population of Saudi already had hijama, whether you like it or not. This is the reality. So when you dealing with the reality, you need to know what are you going to do about it, okay? But they showed good results with low back pain, published results, scientifically based, is really good. And they have now even integrated complementary medicine in year 3 and 4 medical student in some universities. This is excellent. This is really the seed that you put in the generation. So many of these doctors will be already knowing what are we talking about, not like us. We didn't know anything about hijama till we were nearly to retire. What a shame. But these guys, inshallah, now will know about it from year 3 and year 4. That is an excellent achievement. Then Professor Dr. Ali Ramadan, sport medicine, he gave us personal experience. Again, you could see how passionate he was about it. He said he had 5,000 cases with some precautions that he said what to do, what not to do. Then we had an amazing lecture by Dr. Naveen Sharaf from Canada. She's a pediatrician, but she showed us even the Canadian Prime Minister with hijama scars. I would love to take that picture for my NHS manager to say, look, because they will ask me, where is the evidence base for it? So I can tell them, here it is, Canadian Prime Minister, enough for you to convince you to start it. Michael Phillips, we all know that swimmer. We all remember that big muscles jumping with that butterfly style of swimming. They call it freestyle, and the hijama in here and there. I think everybody remember this. And then she used this keyword when you do research and talk: stretch therapy, decompression therapy, vacuum therapy. It's important to use this when you search and you get 1,000 articles rather than one. I remember first time I put cupping therapy in the Google, every article, guess was about what?
Teacups.
No, glaucoma. Because cupping is a specific keyword in glaucoma disease. Nothing to do with our cupping. It's just a cup in the fundus of the retina. So I had nothing. I spent years saying, where are these guys who are practicing? None of them put even a letter, nothing, everything about glaucoma. So expand your keywords and you'll get more results, inshallah. She talked about the indications and she summarized it very well, the scope. Sunnah or detox, idiopathic diseases, and she gave this example of a case, myotonic dystrophy. I have my cases with myotonic dystrophy in my pain clinic, and I know nothing what to do with them. We just shove them with gabapentin, pregabalin, morphine. Now they are coming to ask for CBD, cannabis. That's the next coming wave on us. I have nothing else to offer them. She was brave enough to follow this case, 6 weeks of perseverance, and to get this guy back to work. I can't tell you, to get somebody from chronic pain, terminally ill, to back to work, this is almost a miracle in chronic pain world. I shouldn't use the word miracle, it's a kind of a specific terminology, but anyway. Idiopathic disease, degenerative disease, increased quality of life and palliative care. And she surprised us that her youngest patient was 6 months. That is terrifying. And her oldest was 90-year-old. That is really, really a wide spectrum. Then we heard Dr. Rizka Sirigar from Indonesia, how modest and sincere she was, just telling us how many societies, how many organizations, how many practices were there. Even some universities started to allow postgraduate students to do some research projects. How many books guided to the nurses and books guided to the public. This is something we don't think about. Public would like to read something before they come to your clinic. They don't want to read it from the newspaper or the Saga magazines. They want to read a scientific, simple message that you need to learn marketing. We, as doctors, are very bad in marketing.
Yes.
We either overdo it, so I am the professor, or we don't do it at all. And people just don't know about what we are doing. So we need to get somebody to do it properly for us. Then Mrs. Namat Sibai from Bahrain, she talked about that regulatory body that existed since 2016, and including infection control, medical waste certificate for both medics and non-medics to pass with the exam and certificate to be able to practice. And finally, we heard our brother Sulaiman Ursoy again, the Turkish experience. It was recognized in 2014. Minister of Health recognized it first for doctors and dentists, and then it's opening. I am very, very interested in your research about fibromyalgia. And I wanted to ask Professor Naveen in Canada, what is her recipe for fibromyalgia? Because I have hundreds of patients with fibromyalgia. And I don't know, should I do dry cupping or hijama? Because one of the professors I learned, Ilkay, Turkish Cyprian, is the only author of a English book, cupping therapy. The only English book in the world about cupping is by Ilkay. He's a Turkish Cypriot. He's now maybe 80, 85-year-old, mashallah, and he's still running these courses down in Essex in South England. And when I asked him about fibromyalgia, he said, fibromyalgia is negative, weak patient. The last thing you want is to draw more blood from them. So just do dry cupping massage. I did it for 1 or 2 patients, went well, but that is one single person opinion. I would like to hear a proper study, double blind, randomized, do half the patients wet, hijama, and half dry, then cross over. Take these to this group and take those to this group and see, follow them 6 months or a year. We are not short of patients. We have hundreds of fibromyalgia, and this is going to be really if you look at fibromyalgia patient, the files are like this. Fibromyalgia patients go around hospitals asking every specialist to look at them, gynecologist, dentist for TMG, bowel surgery, orthopedics, depression and psychiatry. And at the very end, they come to you with a file that big. So if you have something for these patients, you're saving your country millions, billions of pounds, and the saving, if it is a public health country, and privately, you're saving them thousands of pounds that they spend in every specialist, and they, at the end, they say, there's nothing wrong with you. These guys will have endoscopic surgery, nothing wrong. They'll have colonoscopy, endoscopy, any oscopy that you can think of, they will have, and every oscopy means thousands of pounds. So if you find something for them, it will be brilliant to publish. And then Professor Merriam finished with a beautiful conclusion again about the Balkan, 250 cases of severe headache with excellent results. He's very humble. This guy sitting in front of you have done 19,000 cases.
Huge experience.
I cannot even think any Chinese practitioners have done 19,000 patients. If you think about it, if you're doing medicine every day for the last 30 years, every day you can see up to 20 patients, okay? Mathematically, as a doctor, 30 years, excluding holidays, etc., you can maximally see 10,000 patients in your career. I've done this much before. When we talk about difficult airway, I was wanting to know, when am I going to reach my difficult airway that might die in my hands? Because the incidence is 1 in 10,000. Okay? So I thought, inshallah, it will be just maybe below, it will not happen, and I will retire before that 1 in 10,000 patients. So I know that in my career, I can only do 10,000 patients. I don't know how Mariam, mashallah, did 19,000. Mashallah, I would like to clap hands on life for you for this. May Allah reward you. And jazakumullah for your listening.